In this section, we will discuss diagnosis and therapy of diseases of hematology, coagulation, and immunology. First, let's talk a little bit about hemoglobin. Hemoglobin has long been studied as a cause of and model for human genetic disease. The most prevalent adult hemoglobin is a tetramer, made up of 2 alpha globin subunits and 2 beta globin subunits. A total of 4 alpha alleles and 2 beta alleles are present in a diploid cell. So mutations in hemoglobin may be qualitative, altering the structure of the protein produced, like sickle cell, or quantitative, altering the relative amounts of the subunits, like the thalassemias. So in sickle cell, incidence fairly common, 1 in 500 African Americans. The mutation, as we discussed earlier, is on chromosome 11. It's inherited as an autosomal recessive trait, and the defective gene is the beta globin, or the hemoglobin beta subunit. The deficiency occurs under low oxygen tension. We get a sickle cell mutation in beta globin, and the HbS, or the hemoglobin S, polymerizes to form rigid structures within the red cell. This is exacerbated in sickle crisis episodes that can be brought on by different stresses. Thalassemias can come in very different forms. There are up to 4 different alpha thalassemias specifically, depending on how many of the alleles have been mutated or deleted. Remember, we said you have 4 alpha alleles, and we see a picture of that right here. If you have one of those alleles mutated, this is known as a silent carrier trait. If you look at the hemoglobin levels, the immune corpuscular volume, and the ratios of A to B in these patients, they're normal. They have normal hemoglobin levels. The immune corpuscular volume is normal. There's no HbH or beta-4 tetramers, and the A to B ratio is practically 1. So really, there's actually no symptomatology in people that have a silent carrier state that have 1 alpha allele deleted, and it's normally only picked up incidentally. Now, if you have 2 alpha alleles deleted, you have what's called the alpha-thal trait. This can either be 2 cis alleles on the same chromosome or 2 trans alleles on different chromosomes. Note here the hemoglobin is slightly decreased, but still within normal limits. The MCV also is slightly decreased, but still on the low normal slide. There are rare inclusions of beta tetramers, and the ratio is still fairly high. Again, not really symptomatic, most of the time picked up incidentally. Now, if you have 3 of your alleles mutated, you start to see a little bit more disease. This is called HbH disease. Hemoglobin fairly low, 6 to 10. So now we're talking about transfusion levels, right? The MCV is also low, small red blood cells. We see more and more beta tetramers forming because of the lack of the alpha subunit, and the A to B ratio is significantly dropped. If you are missing all 4 of your alpha alleles, then this is incompatible with life and results in hydrops vitalis. Moving on to making heme and the porphyrias, we see here the pathway which you all learned in biochemistry for the production of heme. Let's talk about a couple of the diseases that are involved here. One is acute intermittent porphyria. This is a mutation in porphobilinogen deaminase. We see noted in the diagram where that one would take place, where that enzyme is necessary. This is an autosomal dominant disease characterized by visceral nerve attacks. It's treated by guarding against precipitating stresses and giving lyophilized hematin. The other disease that you may want to know for the boards is porphyria cutanea tarda. And here we see where this enzyme comes into play. It's a mutation in an enzyme known as uroporphyrinogen decarboxylase. This is an autosomal dominant photosensitivity type of disease. And so for these people, we treat them by guarding against sun exposure, depleting iron, and small doses of chloroquine. Now, moving on to the genetics of coagulation. We can involve or discuss the intrinsic and extrinsic pathways, factor 10A, 5A, and thrombin, fibrinogen, and platelets. We can also discuss von Willebrand's factor. These all lead to diseases such as the hemophilias, dysfibrinogenemia, platelet disorders, and von Willebrand's disease. So with the hemophilias, remember that both of these, A and B, are X-linked recessive disorders, so you're going to see this in males. Hemophilia A is caused by a deficiency in factor 8, and hemophilia B is caused by a deficiency in factor 9. So if you can remember B9, then that will help you remember. So A is 8, B9. Patients with hemophilia will come in with deep joint bleeds called hemarthroses and require factor replacements. Newly diagnosed boys are given recombinant factors. So here's a question. A 6-month-old boy bruises easily and has bleeding gums on several occasions for 2 months. A maternal uncle has a bleeding disorder. Examination shows several small bruises on the legs. Partial thromboplastin time is prolonged and prothrombin time is normal. Which of the following is the most likely coagulation factor deficiency? Is it factor 3, factor 7, factor 8, factor 10, or factor 13? So what are we thinking about here? There's some key points that are important here. 6-month-old boy, maternal uncle, so this seems to be X-linked, right? That's what the question is indicating. We've got small bruises on the legs. We have a prolonged partial thromboplastin time and a normal prothrombin time. So how do we decide what type of hemophilia we may be dealing with here? Well, remember your pathways, your intrinsic and your extrinsic. Your intrinsic involves 12, 11, 9, 10. Your extrinsic involves 7 and 10. Which one is PTT and which one is PT? A good way to remember it is just to remember PTT is the longer test, PTT. So it goes with the longer pathway, the intrinsic pathway. PT is extrinsic, shorter. So if the extrinsic pathway is affected, then think prolonged PT. If it's the intrinsic, then think prolonged PTT. So back to the question. With the partial thromboplastin time, the PTT being prolonged, and the PT being normal, then you would think factor 8, right? And you would call this hemophilia A. Here we have an example of dysfibrinogenemias. Here we have the pathway. We won't get into too much detail as to how this happens, but just to discuss a couple of the diseases. Afibrinogenemia is autosomal recessive, identified at birth because of umbilical cord bleeding. So that's the dead giveaway on your board's questions for that one, umbilical cord bleeding. Dysfibrinogenias may manifest either autosomal recessive or autosomal dominant inheritance, and you're going to look for bleeding and clotting there. With inherited platelet disorders, we have a couple here that you need to know: Bernard-Soulier syndrome and Glanzmann thrombasthenia. Bernard-Soulier syndrome is caused by a deficiency of glycoprotein 1b and 9, which is involved in the binding of platelets to von Willebrand factor. So the GP1b and 9 are on the platelet surface, and they can't adhere to the von Willebrand factor on the endothelium, and they can't form a clot. With Glanzmann's, the problem is glycoprotein 2b3a, which is actually involved in platelet aggregation and platelets binding to each other. Again, without those present, you can't form a clot. So both Bernard-Soulier syndrome and Glanzmann thrombasthenia are uncommon. They're both autosomal recessive. Patients have easy bruising, nosebleeds, mucosal bleeding, menorrhagia, and occasionally GI bleeding. But look for those bleeding disorder type of questions: easy bruising, nosebleed, maybe epistaxis, and then if they're females, menorrhagia. Von Willebrand's disease, there's 3 different types that you're going to want to know. In this one, remember, we're talking about mucocutaneous bleeding. Von Willebrand's disease is classically characterized by bleeding gums, that kind of thing. So for type 1, it's autosomal dominant, and it's a decrease in von Willebrand factor quantity. Again, mild bleeding, bruising, menorrhagia, bleeding with surgery. Since this is a decrease in quantity, we can treat with DDAVP, and we can substitute that for the von Willebrand's disease and help with this disease. If it's type 2, this is another autosomal dominant picture. This is a qualitative defect in von Willebrand's disease, in von Willebrand's factor. Many different subtypes in type 2. There's a dominant negative effect of the mutated protein that disallows the clot aggregation. DDAVP in this case can be deleterious. Why would that be? Again, because this is a qualitative defect that needs aggregation, that's involved in clot formation. And so if you're adding more von Willebrand's factor or a derivative of von Willebrand's factor, you can actually make it worse. Type 3 is the only one that's autosomal recessive. Severe decrease in von Willebrand's factor quantity, just like type 1. So you replace risacetin and factor 8, and you can help these people. Moving on to the immunodeficiencies, there are a lot of different places for genetic variability here when we get the myeloid progenitors and the lymphoid progenitors coming down. And I won't go all the way through the slide so you can read it, but just to show you the amount of different genetic variabilities and the primary immunodeficiencies that can be the result of genetics. So just to go through a couple of them: autosomal recessive SCID. This is the boy in the bubble disease, right? Lack of adenosine deaminase, okay, ADA. Immune cells have a potent purine salvage pathway, and if you lack this enzyme, you get accumulation of products which block production of other DNTPs by downregulating ribonucleotide reductase. Since this happens, the immune cells can't replicate their DNA, and immunology is all about replication. Those cells have to proliferate. If they can't proliferate, they can't make an immune response. You're going to see low B and T cell numbers. Also, as maternal antibodies wane, you're going to see infants developing many infections and failure to thrive. Another version of SCID is known as X-linked SCID. This is a mutation in the cytokine receptor gene, specifically the common gamma chain, and this is actually the most common form of SCID. The immune cells don't respond appropriately to cytokines, so we have T cells being deficient in their ability to respond to cytokines. B cell numbers may be low, but immunoglobulin levels are very low. You will also see this described as T cell negative, B cell positive SCID, or T negative, B positive SCID. Similar to the other SCID, as maternal antibodies wane, infants develop many infections and failure to thrive. Here are a couple B cell deficiencies that are important to know. Bruton's or X-linked A-gamma globulinemia is manifested by a lack of B cells and their immunoglobulins. It's X-linked. The problem is in the BTK or Bruton's tyrosine kinase gene. You see in this case children that develop recurrent pyogenic infections, especially with encapsulated organisms. You see lots of different abscesses and things like that. Wiskott-Aldrich syndrome is a lack of IgM, X-linked mutation in the WAS or Wiskott-Aldrich syndrome gene. You see recurrent lung, middle ear, and sinus infections, and some skin infections as well. Mostly for B-cell deficiency, you want to look for those recurrent common infections like otitis media that you see here. Complement pathway also has some deficiencies. Most of them are inherited as autosomal recessive diseases. An exception to this rule is the hereditary angioedema, which is actually a dominant trait. It's due to mutations within the C1 inhibitor protein. Now, C1 inhibitor is one of the major inhibitors of plasma kallikrein that cleaves kininogen and releases bradykinin in submucosal tissues. So what happens when you're lacking this inhibitor, you get tissue swelling with edema that come about with certain triggers. Other than that, there are several other complement defects that can lead to variable immunodeficiency type states. Phagocytes, there's defects in generating the oxidative burst. For example, chronic granulomatous disease. Most of the time this is X-linked, about 70%, with 30% being an autosomal recessive variant. This is a defect in an enzyme that is used to generate superoxide or O2 negative radicals using O2 and NADPH. Children develop infections, repeated catalase positive staph type abscesses. It's diagnosed with an enzymatic assay called the nitroblue tetrazolium test, or the NBT test. Myeloperoxidase deficiency is an autosomal recessive defect in MPO, another one of the enzymes involved in the oxidative burst or the respiratory burst that is found in neutrophils and monocytes. Largely benign, MPO is often found incidentally. Some susceptibility to fungal infections, especially candidiasis, in the deep tissues. Another phagocytic deficiency is Chidiac-Higashi syndrome. Here we have an autosomal recessive defect in the lysosomal trafficking regulator. It was formerly termed LYST. Now it's termed CHS1, so you could see either one of those on the boards. There are many defects in neutrophil granules. Other than the immune deficiency, things you want to look for with Chidiac-Higashi syndrome are partial oculocutaneous albinism, easy bruising, and bleeding as a result of deficient platelet-dense bodies. So they get recurrent infections like the CGD kids do. They have impaired chemotaxis and bactericidal activity and abnormal NK cell function. On pathologic exam, they see large granules within the neutrophils on the smears, and treatment for this is bone marrow transplant, usually before age 10, otherwise it is fatal. So some of the other genetic diseases that you want to keep in mind are those that are linked with certain MHC haplotypes. Some of the bigger ones here look at HLA-B27, psoriasis, ankylosing spondylitis, IBD. HLA-DR3 has a high association with Sjogren's syndrome and SLE, and HLA-DR2 has a high association with narcolepsy and Goodpasture syndrome. That concludes this portion of the lecture. Next, we will discuss cancer genetics.